Well, good morning. You're all out there, awake? We're going to spend the next hour talking about care models in motion, the changes being driven by mobile health. And I've got a great panel here with me today, this morning, to cover the topic. We've got folks from the technology industries, the telecom industries, the healthcare industry from both the provider and device and pharmaceutical side. So we're going to start off this morning, and I'm going to ask each one of my panelists just to give a very, very brief introduction on who they are. And I'd like them both to pick two projects or products that they're working on right now in mobile health and just describe why these are some of the more interesting things that they're seeing right now today. So we're going to start here on my right. And Scott, would you introduce yourself? And
Sure. Thank you very much. My name is Scott Peterson. I'm with Verizon in the Verizon healthcare practice. Two very interesting things that we're working on related to mobility. I guess I would start with video. Video for years has been and continues to be a great potential and in some ways a great unknown. Until 4G networks were available, mobile video was difficult to deliver. There were quality of service issues. There remain issues surrounding reimbursement for virtual care and some video interactions, patient to provider, but really does present a great opportunity and a care paradigm and a modality that both patients and providers, we think, will be comfortable with once we sort through some of those perplexing issues. The other one in general around mHealth that we hear from our provider communities is to not inundate them with raw data. They face a mountain of data today. They want significant data to make decisions in real time rather than just more data. So for those of us in a data-intense world with more and more devices and more network bandwidth, we have to be really careful about delivering key decision-making information rather than just dumping raw materials on the providers.
Thank you, Scott. Shannon.
Hi, I'm Shannon Windling. I'm with the Geisinger Health System in central Pennsylvania. And two things that we're doing is we are spending a lot of time on patient-reported data. How can we collect data from the patient using iPads in the waiting room, the patient portal and smartphones, for example, MedRec prior to a visit to help alleviate some of the time constraints in the visit, and all of that integrated into the medical record. And then the second area we're really just starting to explore is around text messaging. And we just launched a conservative weight loss program over text message in association with our GI nutrition department to see if that can really help motivate folks and help them to lose their weight.
Thank you, Shannon. And I'm Donald Jones. I'm with Qualcomm, Vice President of Global Strategy and Market Development, and I wear a second hat, Chief Digital Officer at the Scripps Translational Science Institute. And just to give you a little idea of our interests, we're very focused on cloud computing and the integration of data streams from medical devices with software and apps and with health analytics. David?
Hi, I'm David Yakimischak. I asked you to call me Yak. I'm the general manager for e-prescribing at SureScripts, and we're the national network that connects about 470,000 physicians to about 62,000 pharmacies. Approximately half of the prescriptions in the country are now digital. I'm also the Chief Quality Officer at SureScripts, so my interest is around quality and safety. One project I want to mention is we're working with ONC's Million Hearts campaign, Archimedes, and Community Pharmacy to work with Million Hearts, which is an effort to prevent 1 million strokes and heart attacks over the next 5 years. There's currently a developer challenge running. The applications will provide health screening for a patient, and if the patient is necessary or if it's applicable, they'll be directed to a local pharmacy where they can receive a blood pressure test or a cholesterol screening. We're announcing the finalists today at just before noontime, and I think that's an interesting project to sort of tie together a number of different participants in the community. But more on the quality theme, I wanted to mention patient-contributed data. This is very important to me because I think it's critical that we do include the patient from a quality and safety standpoint. Accuracy and integrity depends on people looking at and using data, and sometimes the patient is the only person who could spot an error. The patient's obviously highly invested in accuracy and completeness. I mean, do you know anyone who cares more about your health than you do? So patient involvement is critical. What that calls into play, though, is the need for two-way communication, because if I get something and I see that I have a question or don't understand something, I need a channel back to the source of the data so that I can ask my question. So these are projects that we're starting to work on.
Thanks, Jack. Scott.
Good morning. I'm Scott Ratson. I'm Vice President of Global Health at Johnson & Johnson, and I'm a public health physician by training with special interest in communication. For 17 years, I've been editing the Journal of Health Communication. And now this is the 4th year at this mHealth Summit, and it's quite interesting and quite a tribute to, I think, all of the fine work here, as well as the promise and growth in the market of the kind of value that we can add in mHealth communication. And a couple of projects that I've been working on are both on the domestic and global front. In our work at Johnson & Johnson, we're not only looking at patients, while patients, of course, are quite important, but more importantly, all of us as health consumers. And in the reach of our products and services each day, we reach over 1 billion people. So how can we also think about some new communication technologies that also provide access to information to help build overall health literacy? So I'll just give 2 examples now, as Don has asked. The first is a new idea that we have, which we call the Digital Health Scorecard. And this ties into an idea of almost like a credit score for your health. But even bigger than that is we presented this at a conference with NASA also on mHealth, and they said it's like a super BMI. So imagine if we have 75% of the numbers that we know contribute to early mortality and morbidities, which we do know, and we take those numbers and we compile those together into with an algorithm on the global burden of disease, and the algorithm that's necessary, that we can actually demonstrate by having a number that we can move or show how populations spend too much on health and have, unfortunately, not necessarily the best outcomes. So there's actually a demonstration that we have here today, the nice part with the pavilion. It's on a Surface tablet here, this Digital Health Scorecard. The 7 numbers can be done in less than a couple of minutes, and it's not a surprise that you would know what these are. That would be alcohol, blood pressure, BMI, blood sugar, cholesterol, exercise, and these roll up into a number that will help make a difference. The other piece that we've been working on over the years, and I know these numbers and these ideas will come up over time, is we piloted one of the first projects as founding sponsor of Text for Baby in the United States, which provides text messages for women during pregnancy, still trying to reach people who might not have access to other information at the right time, at the right place. And secondly, we've also built this in another approach, which you can hear later and also see downstairs. We've helped support the initial architecture and thinking behind MAMA, the Mobile Alliance for Maternal Action. And that also is a project with a number of countries, at least 32 countries thus far, have adapted some of the messages that are used, but it's using mobile to reach women and also their families and also their spouses and also others, with not only text information, but voice and other images and other things that are necessary. So we're learning a lot. I think all of our goals are to build a health literacy and to help the public and the consumer and the patient get better information and continue to have the affinity with the high integrity and necessary evidence behind it, and also provide information and partnership models. Everything that I mentioned, we work both with governments, we work with civil society, and we work in a variety of ways in our role as the world's largest health provider with services and products.
Thank you, Scott. Shannon, I'm going to turn to you first, and you're coming from the background of an integrated healthcare provider system, and we're now facing a world of being fiscally responsible at the provider level for readmissions. Could you talk a little bit about how you are preparing and what you're actually doing to take care of those now mobile patients that you're responsible for fiscally once they leave your doors?
I think most of what needs to happen with the patient happens outside the doors. Certainly with a hospital readmission, you have them for several days, but you're really dependent on them to follow up with their care at home. And if it's just a clinic visit, maybe you have them for 15 minutes maybe if it's a specialist visit, you get 30, but it's a very short period of time. And so what we're really trying to do is see what we can do with technology to fill in those gaps. So what can I do, for example, if you get home from the hospital, the recommended treatment that we prescribed is that you see your primary care provider within 7 days. There are also certain risk factors, maybe based on what you have, if you came in for a heart surgery or things like that. Can I send you a patient questionnaire that asks you a few questions to let us know if you're having difficulty and maybe get you in quicker? Can I use text messages or reminders through the patient portal to make sure you understand the value of that follow-up visit? So I think the communication is a way for us to be able to touch the patient when they're not inside the office. And we have a lot of opportunities there because it may be 6 months before the patient comes back. You can touch them in a lot of different ways in between times.
Scott, from Verizon's perspective, are you starting to see some requests from the provider community on how you as a telecommunications provider can address this issue?
Yes, we are, and it's right along what Shannon was talking about. Providers and these extended care communities are thinking about technology being a way to help them with the readmission issues, and it's really interesting that we can extend care and use technology in a way that is so much more efficient than perhaps traditional models of call centers or deploying people out to the home in a home health setting. The other thing that's really perplexing about this issue is that we've started to see already some shifting in the industry. So companies that have grown up as home health providers are starting to think more like traditional in-house providers, and care communities like Shannon's are starting to think like home health providers. And so I'm already imagining and starting to see some combinations and partnering there as the care models really combine.
Scott, you're predominantly on the pharma, device, some services side at J&J. How do you at J&J look at how your product line is going to interface beyond the acute care setting as patients are mobile, but the acute care setting is basically saying we're financially responsible and we've got to actually turn to our vendors for help?
Well, Don, that's a real important question. One area, though, I think that most people associate Johnson & Johnson, if I say how many of you know our shampoo or our baby powder, and how many of you can think about what that smells like, that's our connection. We also do have a large pharma sector and the largest medical devices and diagnostics, so I'm not saying that those are not important. Clearly, there's a lot of the areas that we're engaged in, and that's where we do touch the patient in many cases or the consumer. Another area we're engaging in, and I think there's a lot of people have compliance programs, and we all know that it's not just the diagnosis from the physician and the prescriber, but also how people are compliant with their activities, also dealing with readmissions and so forth. So we believe even programs such as Care for Today of giving people opportunities to link both with reminders on medicines, reminders on appropriate visits, a lot of these other pieces are important. So what I would say is that I think technology is integral in the new marketing mix. And tomorrow Kim Cadlick will be speaking on one of the plenaries, who's our Chief Marketing Officer, who will bring those pieces together. So we have social media, which is also a part of this mHealth, shall we say, stickiness of how people are getting their information today. We work with the other communication strategies that are still there. We still have the regular media, shall we say, the mass media, the narrowcast media, the specialized media, and even what we're learning with some of our new projects for the Text for Baby. If you don't have old posters and outside advertisements, you're still not going to be able to get people to get to the new technologies. So all of this wraps around the consumer experience or the patient experience, and we believe we need to do this as appropriate with the right evidence base.
I'm sorry. Let me just follow on with the patient compliance piece. Your success rate is dependent on the patient actually following your instructions. So again, you can only watch them so much. So in line with what Scott said, I think we really, from a healthcare perspective, need to take a lot of lessons from companies that know how to market well. If I could get patients to remember to take their medications the way that Coca-Cola can get people to remember their slogans, we would all be in a lot better shape. And that's really the mindset we have to look towards. And I think when we approach mobile technology, we're looking at how can we integrate healthcare into somebody's existing lifestyle. I'm not trying to figure out how to get you to come over to my way. I'm figuring out how do I take your smartphone, your Facebook, your Twitter account, etc., and get that integrated with how you approach healthcare to get you to pay attention.
I would just say on adherence, what the technology allows us to do is maybe have an idea that someone's not adherent, but I don't think it tells us why. And I think the connection that the technology can give us is to get those notifications and have that contact. I mean, when it comes to adherence, the pharmacy may well be the first person who knows that you're not adherent, because if you don't pick up your medicine, there's no chance you can take it. Now, we've got that connection with the patient, so you haven't come in to pick up. Why? Well, now we can not only be in contact with the patient, but maybe with the doctor, with other family members, and there can be more of a group effort to find out why, because really we need to get to why someone's not adherent.
Right. Are they just forgetting to take their medication? Is it a financial issue? Are they having trouble getting from their house to the pharmacy to actually pick up the medication?
Or maybe it's making them feel sick. I mean, you know, maybe it's not it's not the magic bullet, and we need to get in contact with these people, though, and get them back into the discussion, or else they're gone.
Right.
I think the interesting and key for me in that conversation is Shannon's point that you really have to take it to the patient. I mean, there are patients that only want to communicate via email. There are others that are texters, and there's a whole population, tens, depending on hundreds of millions, that want social. And so how we integrate and how we take information about their individual care, their scores, what have you, and use social media to connect with them in a way that they're comfortable, in the same way they communicate with their broader, life ecosystem every day, we'll have better adherence.
So Scott brings up a really good issue. So Yak, maybe you can describe how's the EMR, EHR of the next 3 to 5 years going to deal with this, move beyond the hospital and the doctor's office?
Well, certainly there's the connectivity models are going to have a big impact, but I do want to mention that it's not all paradise right now. Mobile devices are used extensively in e-prescribing and used in care, but they're not perfect for everything. We find that the form factors and the screen displays aren't always complete enough for some of the very complex applications. I mean, if you've got a data-rich application with a lot of graphics and a lot of things going on, fitting that onto a mobile device is not probably the way to go. The mobile device is oriented towards convenience, speed, and so if you're just, walking from patient to patient, or on the weekend responding to a refill authorization, or something sort of convenient, it's appropriate. But what we see now is a pairing of a mobile application with a desktop application, so that you can take advantage of the form in its right place. And so I see that being sort of the trend here when you say the next 3 to 5 years, is not that everything is mobile and only mobile, or that everything's desktop application when you're in, say, inpatient or in a fixed setting, but that there's going to be this continuum. I have an iPhone and an iPad and a desktop computer and a phone, and I think there just needs to be transparency amongst these things and take advantage of them for the thing that they're most designed for, as opposed to try to make it a one-size-fits-all and solve every problem.
But you're coming from an industry which right now has a right mode, meaning physicians write to your system, nurses write to the system. In the next 3 to 5 years, are patients and patients' families going to write to your systems? I
think absolutely. And they already do in some way. It may be disconnected. There's always these spheres of control and spheres of influence. And, while the patient is at the extremity, in fact, they're at the center. And so we're all sort of layers away from them. But I think that they do already. And they, through their actions, through visiting their doctor, getting a prescription, filling the prescription, whatever that may be, they're already interacting with and influencing the data that's in the network.
So Don, we have a pilot to that effect. So we're doing medication reconciliation prior to the visit. So what happens is a couple of weeks before the patient's visit, they actually get a questionnaire that comes through the patient portal that pulls from the medical record the medications that we believe they're taking. And what we do is we ask them, are you actually taking these medications? Are you taking them in the way that we think you are from a dosage and frequency perspective? And if not, why? We try and find that answer out. And then what else are you taking that we don't know about? Are you taking other prescriptions that we're not aware of? or are even over-the-counter inhalers, creams, lotions, things like that, really help us do a better job for the patient. Now, currently, we have a pharmacy team interface with that data before going directly to the medical record, but we're currently looking at some risk stratification models where certain types of updates would go directly into the medical record. Things that are more complicated, like narcotics or complex medications, would then be reviewed by a pharmacist and consulted with the physician.
I'm sure you're going to find a lot of surprises.
I mean, we've already found that about 16% of the patients aren't taking the meds that we think they're taking, and probably more surprising is 21% are taking meds that we're not aware of. And given the importance of medication reconciliation and medication adherence from a safety and quality perspective, that's been very important information.
Yeah. We've seen very similar results in the pilots we've done to what Shannon's talking to. Don, I think a point you made that we can't minimize here today is about EMRs and EHRs, and even to a certain extent some HIEs. The sense around data and who owns data and how data is accessible and easily reached by providers and patients has to change. We cannot continue to have walls that block APIs, block open standards, block a consumer's right to get to their health information in the device they want, in the modality they want, and in the use case they want. And that's all of our responsibility. Each of us sitting here, based on where our companies sit, has a role in that, in the ecosystem, but we've got to be loud on that one. We cannot continue to set up trials or even live deployments like Shannon's talking about, where it takes 9 months to do the integration with an EMR. That's just not acceptable.
I'm sure data and integrated data and open APIs is going to be a common theme here this morning, but I want to switch gears for a moment and go back to Shannon. And we know in a hospital setting and even in a physician's office setting what a rapid response looks like when you need it, and how you intervene quickly to make things that may be going downhill stop and maybe at least even out, if not actually improve. So as people are at home and we're trying to lower cost structures and trying to keep them from hitting that ambulance, that ER, and maybe get admitted back upstairs again, how is a hospital organization or a large physician group going to manage the equivalent of remote rapid response? And I'll just take a broad definition of what rapid response means there. But how do you intervene so you don't end up paying thousands of dollars, if not tens of thousands of dollars, because you failed at the rapid response concept?
Yeah, and that's actually quite a significant question when we talk about any of these projects. Not to diminish the value of the technology, but that's usually the easiest part of the project, is I can figure out how to put it in. The question is, what am I going to do with the data that I get from it? So, for example, one of the national best practices for persistent asthmatics is to deliver something called the asthma control test every 90 days. It's, depending on age, a 5 to 7 questionnaire. It's very quick and easy. And the idea is if you check in every 90 days, you might be able to catch somebody who's having a problem. Because patients aren't really great at having a problem and just calling their doctor's office and say, I'm having a problem. They wait to see, is it really bad? Let me wait a couple more days. So I send them a quick questionnaire that they can either answer on a smartphone or through a web portal. And based on that, it generates a score. And it's a nationally validated instrument. And that score tells me whether they're doing okay or not. And if they're not doing okay, I might ask a couple of different questions. I might say, have you been to the doctor recently? So maybe you were in there a couple of days and they changed your inhaler prescription. But if not, that actually response flows into an in-basket in our medical record, and that patient gets a call from a nurse to follow up and see what's going on. Now, the problem with that is that's a human being having to call. So there's a lot of back and forth on the value of that, and do we have enough people to staff all of this various technology issues? So, so far we're doing okay, but it's a big question on how that might change us over the years.
And I think what Shannon mentions here is the abilities to have a score when you're dealing with secondary prevention, such as asthmatics. There's a lot in diabetes, of course, and other areas. What we're talking about with this digital health scorecard is to actually simplify it so you don't have these big EMRs, EHRs, HRAs, all the lexicon of letters. Come up with 7 pieces that give a score that show up on your screen, your mobile device, whatever, that it can change over time. reminds people if they're hypertensive to know what their blood pressure is or are they taking their meds, reminds people if they do want to exercise more, they can do that piece of it. And it also is a way to cut through the clutter. We're trying to help simplify pieces also with checklists. So if I am hypertensive or I am over 50 and my doc reminds me I should take a low-dose aspirin every day, that I may need an opportunity to have that also linked in with whatever score I have and how I can move it. So I think there's some simplicity here that we can do on the primary prevention, global health, where 75% of disease is preventable. And then there's when we know people have disease, asthma, diabetes, and so forth, similarly take a very well-connected opportunity to reach people at the right time and give them the right information the way they want it.
So I agree that one of the first steps is to get patients the information. I think what we've not figured out is how to get the patients to actually act on the information.
So what buried in here is potentially some indicators that would suggest the call center industry, the medical call center industry, is going to grow, and that maybe use a wide variety of both human-based and technology-based messaging out of it. Scott, you operate call centers, you advise people on call centers. Do you agree that medical call center is a growth opportunity because of these new responsibilities?
I do. I do believe the industry will grow, although I'm not sure it will be in the traditional linear sense of just putting more bodies in a call center. That's a huge cost driver to the system. So I think Shannon said it well, in that there are many times that the interaction from a call center, a smart call center, can be via social media, it can be via text messaging, can be other communication technologies. So if we do that, I agree the call center industry will grow, the contact center industry will grow. I think the key to doing that efficiently is analytics, and pardon the buzzword bingo out there, but without the right decision-making capabilities and computing capabilities that are taking all this raw information into a call center, it's really difficult for an agent, sitting in a call center to decide how Scott should receive his information about his hypertension or his lack of adherence. So that's where we're really going to rely on supercomputing and analytics and big data, check, to do that much more efficiently.
So I'm going to ask the other Scott here, because he's the token physician on our panel, to put on his physician hat for just a moment and respond to the notion that call centers or people managing other people for messaging purposes in healthcare, meaning I'm a patient, I'm calling, I have a question, I need help, ultimately, usually, traditionally ends up filtering to the physician, and hopefully you get a phone call back at some time. Not a very efficient, convenient kind of system. So my question to you is, how do you see things evolving, both from applying technology from a standing orders perspective, meaning we know what the message is going to be even though the machine decides when to send it out, and then also even on a people basis, do you see the world evolving where we empower nurses or other folks beyond what we currently empower them to do in order to shorten the time frames, make things more convenient, and cause the interactions to happen much more efficiently?
Well, thanks, Don. I think you answered the question at the end really by saying that the workforce is going to continue to devolve. There's 26 million health professionals around the world. The docs, if we want to say, are more at the, quote, top of the pyramid with a smaller number. The nurses, there are more nurses and so forth. And the most highly paid person in the chain pharmacy stores is behind glass in the back of the store. So how do we get even the pharmacists and others to be able to communicate better with messages that are beyond the pre-programmed opportunity? So I think to answer the question, yes, there's a standard protocol, and we have to touch what Yak was saying on the quality, that people are getting the right information from a trusted source. But we need to realize, and the physician groups also need to open up, that some messaging and some ability for people like me or patients like me is not coming from the doc in the old white coat. The ethos is changing, and I think all of society is changing also, as we're more used to physician assistants, nurses, and others that not only prescribe but give advice. So I think we're going to continue to see a devolved workforce. It's also going to be a place where there's job growth, which is also a big buzzword in this town. So hopefully it will all come together.
And do you translate that as scope of practice growth at some of the levels of folks that maybe historically we've limited what they can do?
Absolutely, I think so. I think even when you start to see anesthesia move away from the the anesthesiologist with an MD to others, I think you'll continue to see the devolution in other fields as well.
One comment I wanted to make was that the point of this technology is not for its own sake. I mean, it's obviously to provide better information, but also to provide more time so that you can actually spend time with a patient. You know, get the pharmacist out from behind the counter, let the technology do the work, and same thing with my personal or with patients' use of information. Give me time now to have an informed discussion with my care provider instead of us managing paper and moving information around. You know, the other thing that I hope this technology provides is that there's a large number of people who don't get involved in their own health management, and they don't really get connected. They may be perfectly healthy right now, but you know, I know as time goes on, it doesn't always stay that way. So I'm hoping that through ease of use, ease of access, very lightweight, whether it's social media in the world where they live, texting, or wherever it is, that people can get connected with their health and take a personal interest, take a personal responsibility. And I think we have that responsibility to them and to us to provide those tools and those capabilities so that they can.
So, yeah, could you comment from an EHR, EMR perspective, as we wire people up to machines in a healthcare system or run diagnostics, et cetera, and complete information databases as part of those systems, and then send them home, increasingly still wired up somehow. What's the role of the Allscripts of the world and other EHR providers in that role? Is that going to be other companies managing those IT systems, or do you see the hospital systems spilling out and being part of the management of the patient at home, or
well,
how do you
now
see
this
that
is
evolving?
this is my personal perspective, but I think it's absolutely the EMRs are a portal, are a connection point, and a critical connection point, not only within the facility, but also to the outside world. Not to say that that's all there's going to be. I think, you know, there was a comment a little earlier about all these different applications, and I agree. I don't think we can have 20, 30, 50, 100 health applications. So something has to pull this together. But I think that there are some significant groups or bases of information and service, and the EMR is absolutely one of those. It's a system of record, so it absolutely has to be included. I don't think it's everything, but it's certainly an important piece, and it's probably that gateway to the outside world.
I would agree with that, and I think one of the challenges that when we start to look at mobile apps being involved in patients' care is there's, you know, hundreds of companies that have developed cool apps. Some are, you know, pretty basic pedometer type things. I'm working with a company now who has an app for cardiac rehab, which is a lot more complicated topic. And a challenge for us as we try and look at how do we use these is I need that data to come back into the EMR. For me to ask my doctors to look at 4 different systems to manage their patient is just never going to happen. And so I need the EMR to be central. As you said, I might need a data integration level that sits on top of the EMR where all of these different devices can feed the information and have it come in. But the EMR really is our central source for medical decision making, and I don't see that changing.
You bring up a really interesting point with this cardiac rehab app. One of the big challenges with new apps, especially the more clinically complicated one, is are they clinically validated? And often they're not. But then I would also argue that the old system of here's your instruction set, go home and follow it, that was never clinically validated either, and perhaps has any number of failures built into it. So how are you as a healthcare system looking at making decisions about deploying an app that may be at the very beginning stages of figuring out whether it's actually going to be clinically relevant?
Right. I mean, I have the benefit of sitting in a division called the Division of Clinical Innovation. So we're specifically charged with trying new stuff, and we do have the ability to fail, so it's recognized that not everything we try is going to work. So I think having that kind of cultural acceptance is one step. In terms of evaluating a specific technology or a project, I really look at, between myself and my clinical sponsors, is kind of, to be honest, a gut feel on whether we think this will make a difference. So with the cardiac rehab app, the business case is about the current cardiac rehab process, which is a 12-week program requires the patient to come in 3 days a week, has been demonstrated to be immensely successful in reducing future heart problems. However, has an extremely high dropout rate because of the physical presence required. So if I take that and then I look at what the Cardiac Rehab mobile app is trying to do, which is find a way to integrate between the on-site and the off-site care and still deliver that rehab process, I can see those two marrying. And so I look for a significant health issue and a health problem that the technology might be able to solve.
So it sounds like you've adapted kind of a Silicon Valley approach to think smart, try smart, but if you're going to fail, fail fast. And then try again.
Exactly.
And
we don't want to fail slowly.
I want to ask Scott, are you seeing that sounds pretty innovative for a healthcare system. Are you seeing more healthcare systems come up and think a way a technology company would think?
We are, although not fast enough. I think about what apps are going to win, and the genesis of your question there. I think we have to remember there's two spheres of that. The consumer sphere, people are going to be uncomfortable in this industry. Consumers are going to demand more and more. Code will be written, apps will be deployed that change the way both payers and providers allow patients to access information. And the boundaries will continue to be pushed, and the market will sort which of those applications end up getting large volumes of patients. I think the other sphere of that, from an enterprise perspective, is fail fast. I agree with Shannon's overall theory, but the companies that can document, via white papers, IRB boards, et cetera, better outcomes, lower costs, boy, you're going to see the market run to those very, very quickly. So, that's always my filter when I'm at, big shows, this one, HIMSS in New Orleans, et cetera. I mean, you can filter out the noise pretty quickly if you start asking some of those questions.
So what's interesting in what you just said, there's probably a couple of angles. Those things that appeal to the consumer, perhaps they bring convenience, information in their hand, and may actually shift essentially what I thought of referral patterns, but essentially market share, because the consumers actually start showing up where maybe an app gives them access that previously they didn't have. I'm thinking ZocDoc as an example, appointment making application. So that's one side of the equation. The other side is what the healthcare entity is actually doing, saying we're actually doing what we do better, and we can prove it. These two things seem to be operating somewhat in parallel, and you may actually see the consumer go this direction while the health plan is saying, yeah, but we're over here doing something better.
Perhaps, although I think the risk of that is a little bit mitigated. Well, I think it is mitigated because ultimately the consumer wants more than a slick app on their phone. The consumer ultimately, the patient ultimately wants the same thing the providers and the payers want, which is better outcomes, easier access to care. So I agree with you that the development cycles may be moving at different paces, and perhaps it looks like they are parallel paths at some times. But the savvy consumers know which apps actually work and actually get EMR information to them securely and efficiently, and the savvy payers and providers know what apps appeal to consumers and start to really increase adoption.
Scott, I'm going to throw a question to you, partly because J&J's in 300 plus or minus businesses, and so you see the world of healthcare through an awful lot of lenses. And it seems to me once you leave the hospital, we've got a lot of siloed providers out there, not that we don't inside of the hospital as well. And if we're going to coordinate care between DMEs, home health, home care, EMS, and anybody else that care, family members, the patient themselves, if we're going to have any ability to kind of coordinate things in any relevant, timely sense, what is it going to take to kind of bring together the general contractor kind of role to make sense of that person's care outside of the hospital while keeping a goal in mind of what's keeping them from going back?
Sure. Well, it's a huge challenge, obviously, of how we would be able to look at all of that. And I think it ties to what you were asking Shannon on how to come up with the right protocols and what are the different pieces that come into place here. And we often look at this from a health literacy lens, that if health literacy is the center, that we want people to help them make the right decisions at the right time, we need a system that has simplified demands and complexity and a more educated populace to know what to do in terms of health matters. So if you take the whole continuum of care, as it may be, from hospital to home or the whole health area, there are different pieces that people need to do at different times. And what Shannon was mentioning, we've been looking at the idea of using checklists. And this ties really in the global environment. There's a United Nations Innovation Working Group on Women and Children's Health, and we were trying to look at what are some new technologies. We, Johnson & Johnson Norway, chair it with about 40 or so different groups. What are some of these technologies that can jumpstart innovations in safe childbirth, in pregnancy and motherhood and so forth? And we actually found some of these. There's a safe childbirth checklist that Harvard's been working on. There's an mCheck tool that WHO has put together, but it hasn't been scaled yet, 7 days postpartum. There's a lot of these tools that are out there, and this checklist work is built upon what works in other industries. So the short is that we think that by taking checklists and simplifying them, that could be both on mobile devices, and I'm using not just phones, and also what Lancet calls frugal technologies, old paper-based checklists, pieces that you can use this digital scorecard and print it out and look at the green, yellow, red and take it to your physician or take it to your nurse practitioner or take it to your pharmacist. Those are the kind of pieces that we're looking for. So I think that there's a way of integrating the technologies, using checklists of what people need to do at different parts, and be able to figure out a way that this will have better health outcomes.
Yeah, I mean, I think certainly, again, the patient has responsibility, and better educating them helps with the process. I think we also have a tremendous opportunity with things like health information exchanges. You know, I'll put a plug for whatever you think about meaningful use. It has gotten more doctors' offices to put their medical records electronically, and having them electronically means that you can share more data. And so if a provider can access something like a health information exchange when a patient comes in and sees that Shannon, although I'm coming into a specialist, I was also treated at this hospital, and this was my care at the family practice center that I went to, that gives them a much better understanding of what my condition is, what kind of meds and treatment I've been on, and they should be able to come up with treatments that are better suited for my specific case.
I'm going to ask the next question of the two Scotts first, and then I'd like both of you to weigh in from your perspectives when we come back to. But with the implementation of Obamacare, we're likely to see a large number of people with ultimately high deductible health plans, kind of the old-fashioned 1970s version of a health insurance plan, meaning first dollars are coming out of pocket. That's going to open the door to a lot more consumerism in healthcare. And so I'm asking you both, because you have consumer products backgrounds as part of your overall companies, I'd like to have your perspective on how consumerism will play out given the way the insurance is likely to grow in that high deductible plan. And then perhaps, Shannon, if you could weigh in from a healthcare systems perspective, how do you play into it from wearing a consumer hat, and you from a information technology perspective? So, Scott, you want to start?
Sure, I'm happy to. I think ultimately consumerism is only a good thing for the industry. It reminds us all where the ultimate accountability and ownership of information and decision making ought to lie, and we get lost in that sometimes. It forces us to think differently about technology. It forces us to think differently about privacy and what we regulate, and also even ultimately what we pay for and what we don't, either as a society or as a private company. So, you know, I believe in the power of consumerism. I believe that, you know, the market is savvy, and as we get more and more disaggregated information, back to my point about breaking down some of the walls around data today, I believe that we'll see great advancements in people starting to take more accountability for their care, so that perhaps we don't have to spend so much time thinking, is this checklist right or is this checklist right, but people start to take some ownership ultimately of their wellness.
I think Scott is right when he says ownership, and I think that's really the key. And our hope is to have a health competent consumer. So a consumer is competent to make decisions, not just when they choose a device, which they'll ask a lot of questions, but maybe when they choose a physician or choose a health plan or choose to do something different in their life each day. So I think the health competent consumer is one direction moving forward. At the same time, health is not just about medicine and health facilities and the fields we all live in. Health is well-being, health is happiness, health is caring. So we have to figure out a way to have the technologies care with the consumer. We say caring for the world one person at a time. That's our J&J motive. But how can we use technologies in the same way to not only be a conduit, but also have this other bridge? And I say that now because I'm thinking 10 years ago, half the world's population didn't make a phone call. 20 years ago, text messaging just began. What's next? And these devices are ubiquitous. I've heard one time we're going to change this from mHealth to UHealth, right? To call it, that was a couple years ago, but I think mHealth is stuck. So how does the consumerism caring element, and I think the Obamacare and health reform is going to provide a great opportunity to get consumers more engaged in healthcare.
Yeah, I think I would echo those thoughts. I think the more that the patient takes responsibility for the quality of care that they get, the type of care they get, and what they do themselves, the better off we're going to be. There's a lot of very unfortunate diseases that hit people, and those are very tragic. Likewise, there's a lot of things we do to ourselves just because of the lifestyle we live, lack of exercise, the types of things we eat, the amount of sleep we get, the stress we cause. And it's been hard to get people to pay attention to that when it doesn't directly affect their pocketbook. And, so maybe tying that directly to, okay, that 30 minutes of exercise I recommended that you get every day, you not getting it is going to cost you $500 more a year. That's a better connection than what we're making today. I don't know if it's going to be perfect, but I think it moves us in a direction where consumers are taking more responsibility for the type of health care they need, their own actions.
Are you seeing the discussion in the Gessinger boardroom move to how do we become more consumer-centric?
I think we are talking a lot more about patient preferences than we did. A lot of that is communication preferences, and we talk about phone calls versus email versus text messages. But there certainly is a lot more discussion about reaching the consumer the way they want to be reached, rather than the way we have maybe traditionally chosen to send them a letter or do a visit with them.
And I would say I'm going to come back to accuracy, quality, and safety. We're going to have much more informed patients. This is both an opportunity and a risk. The majority of people who are taking a medication cannot tell you exactly the name, strength, and form of what they're taking. So they're going to trust what they're seeing in a piece of information that they're getting, and they're going to make decisions based on that. And if it's not right, we've really done a disservice. On the other hand, I think we have an opportunity here, as I said, by consumers now being part of the equation. They're going to participate. They're going to, but they're going to ask questions, and they're going to need answers, and they're going to need communication paths that don't exist today. But I would say, in my view, quality and safety does not get enough attention, especially when we're talking about the clinical applications, those that are really significantly involved in patient care where accuracy and precision is important. I mean, if you're counting how many steps I took on a pedometer, that's one thing. But if you're taking some very sophisticated measurements at home, or you're working on your medication dosage, that better be dead right.
Yeah, absolutely.
I'm going to switch gears here just a little bit, but stay in the topic of kind of consumerism, and I want the panelists to talk about and look forward to things they wish they had access to, but may not know that they're available, or how they could get access to them, or if they could work. So in other words, the tools you wish you had, but they don't exist today. And so in that front, some of you may know that Qualcomm has sponsored a prize called the Qualcomm Tricorder X Prize, with a $10 million prize. This is an article from The Economist about it here that just came out last week. This is a prize that has about 300 teams pre-registered from around the world to try and invent a machine that can be used by a consumer to diagnose 15 different diagnoses without any additional help from a healthcare professional. This is definitely in the category of something you might wish you had, but doesn't exist today per se. But it's a real contest, a real $10 million prize. There's another $2.25 million that Nokia has put up around various sensors. And the hope among many folks, certainly Qualcomm intended, is that we actually get a working model. Maybe not an FDA-approved model, but a working model. And I'm going to go to you, Scott. Conveniently, when I printed this out, the Verizon banner came out at the top of the Economist article, so I guess there's some endorsement of sorts implied otherwise. But maybe you could think about, from your perspective, of devices that you wish were there in the marketplace going forward, and what you think of it from a telecommunications company addressing the healthcare world.
Sure, and that's not by accident, by the way, that the Verizon banner is there. I think, you know, the I wish it were here today question for me is answered around this whole sphere of personalized medicine. And, you know, there's facets of it in supercomputing and the genome projects and other advancements that are happening there. But clearly, to do that, not just in the United States, but around the world in more developed nations where even going to a clinic is a big deal. You know, we think about the leap that we have to make, but, you know, I know, Scott, you see it in your work around the world. That can only happen with an open mind about cloud computing, supercomputing, shared data, service models, and the ubiquity of information that has to flow to consumers, to whoever is paying for the service, in addition to the consumer, and to the provider of the services in real time, is a big, big leap from where we are today. And certainly at Verizon, you know, we have many of the toolkits, or, you know, items from the tool chest that help people get there. But we really have to start to think differently about the power of cloud computing and supercomputing to achieve that mission.
But what does J&J think of this world of arming consumers with new devices yet to be invented?
Well, there are teams of people all throughout in our decentralized approach working on this. Everything from how do we go from a diagnose to treat model to a predict and avoid, or predict and prevent model. And how can we do that in the mental health space? So you may be able to have a pre-tremor or something like that, let's say, for example. But what if there's something more, that we have better markers that we could find that would predict Alzheimer's, and we hopefully would have something to help either delay it or avoid the sequelae? These are the kind of things we're looking at. How do we predict and prevent? But also, if you had my one wish as a public health guy, is how I could cut through the clutter this moment and have everybody to think about their health and think about 3 things that they would do differently or better for themselves and their families in the next day or two. And even if I say that, I know people are multitasking, or using different devices. Getting health front and center in somebody's mind is not an easy task. And they tend to think about it when they're sick. If I asked all of us, how many of us are patients? A lot of us will not raise our hand because we are not sick right now. But we're talking about reaching people when they're patients, when they care. So we're trying to think about ways in the consumer-driven environment that we're in this overconsumption, 3,000 messages a moment. How do we get people to think about health and to think about it differently? So I think that's the challenge we all face. I think every year we'll just have more pieces coming here, but hopefully we could predict and prevent as well.
Yeah.
Our company, we don't have the answers. What we have, though, is open ears, and I think that's really important. Right in this conference alone, in this room alone, I'll bet you there are dozens and dozens of great ideas. We don't have $1 million, but tomorrow afternoon at 3 o'clock, I'm going to be in our booth. We're inviting people to come and give a pitch. It'll be a rapid-fire format. Come for 3 minutes, give us your pitch on what's your idea to our business development team, and we'll pick the winners and invite you back to our office and maybe do a deal with you. You know, I think that's what's going to take. It's, you know, we can have some great ideas, but I think the ideas are already out there. It's a matter of latching on to the right ones, putting them together into the right packages, getting the deal right and the incentives right, and then running with some of these things. I mean, we don't have all the ideas, but they are in this room.
Shannon, do you find in the healthcare system where some of these ideas are potentially disruptive to the traditional delivery models? Is that a challenge or is that an opportunity?
Well, I make a lot of people anxious, which is probably an understatement because we are trying to do new things. The questions come up very frequently, you know, how is this going to save me time, or how is this going to actually benefit the environment? So the clinical workflow is extremely important. I don't do anything without a provider champion. So, you know, being in a department where I think up these things and work with vendors, I always want to get a, you know, sufficiently high up clinical sponsor that will really say, this is important to our patients, this is important to the way that we do healthcare. But we've had a number of challenges. When the patient portal came out and patients could message doctors, there was a lot of pushback about how much time that was going to add to their schedule. Excuse me, and they weren't going to get compensated. We had to do some incentives. Now it's pretty much standard course, but there were a lot of cultural hurdles at that time to get over.
Let's switch gears to another topic that I defined around the concept of prescribing an app. But I don't mean an app from the perspective of just a piece of software downloaded to your smartphone or your tablet. I mean the concept of some combination of a drug or therapy, perhaps some software in the form of an app, and perhaps one or more devices, all coming together as something a physician says, you need this, and I'm going to prescribe it for you. I'd like each of you to talk a little bit about this concept, both from do you see it coming and how fast do you see it coming, number one, and number two, what's it going to take to actually bring a software app, a drug or a therapy and a device together and get them into a patient's hands in a way that's actually usable? Who's going to do that? Who's going to fulfill it? Do I get that at the Verizon store? Does J&J do it? Is Walgreens going to pull all that together for us? Where is this going to happen? So, Scott, you want to take it?
Sure. It really combines the concepts that Scott was talking about, that the model has to change from diagnose and treat to be well, right? Live your life, be well. But at the same time, Dave's very real warning that the information that's critical at the decision time needs to be right? Needs to be the best available, you know, given the situation. So, you know, to your ultimate question about who provides it, time will tell, you know, where that aggregates. There are a couple of natural points. You know, will it be one ultimate provider system? Probably not. Will we concentrate to one payer, either private or public? Probably not, at least in the US. So, you know, stepping aside from predicting where that centers, I think the concept is the right way to think about many of the things we've talked about today. Accountability, responsibility, wellness, and at the same time, you know, breaking some glass. You know, I think more and more people like Shannon need more and more power in provider systems, as a plug, because, you know, this is a bit of pandering, but to quote my chairman and CEO, Lowell McAdam, you can't change without change. So you're going to have to take some big steps. You've got to continue to make people uncomfortable, and all of us in the room have to make the system uncomfortable. It's the only way we're going to really move the needle that we all needs to be moved.
Yeah, can you help facilitate prescribing an app the way I just described an app?
Oh, I think absolutely facilitate. I mean, where it's going to come from, it's an interesting question. I think it could come from a lot of different places, and there's a lot of different players that could do this. But clearly, the touch points with the patient are going to be around their doctor, their pharmacist, maybe their payer, maybe their employer. You know, but these are all channels of delivery. Where that packaging comes together could be pharma, could be actually different in different situations.
Scott, J&J went completely around this question and put an app in the hands of consumers in the form of a Muppet augmented reality app that you and I spoke about, where you can buy J&J brand Band-Aids with Muppet characters and hold your tablet or smartphone over them and watch Kermit come to life. So you're already in the app business. Maybe not this is the mom prescribed version as opposed to the physician prescribed version, but J&J has got to be all over this space.
Well, I'll answer personally that I think this needs to be led with a science and evidence base that is physician-led, that has the healthcare group at the center. That doesn't mean it has to be a physician group, but I think this is a multidisciplinary approach. We're looking at, obviously, it's a different consumer that at a time when they have to take care of a Band-Aid with Elmo than they might be when they're making a complex decision on how I'm going to manage my diabetes and use our diabetes meters that LifeScan makes. It communicates and puts pieces together and has a Care for Today compliance app program and so forth. So there's lots of different ways that we're seeing how this comes together. My short answer is, I think a digital health scorecard, or people having a score, and then they find out ways that they can make that score go up or down, which could be a mobile health application that could link with a quick text now from National Cancer Institute to stop smoking and be able to buy medicine or nicotine replacement therapy if that helps, whatever it might be. But a score where they can make behavior change and reinforce those and incentivize it, much of the way we've all been talking about today. I think that will be the app of the future, that we're caring for an individual, and the individual is able to gauge this over time and hopefully prevent disease. And when they do get sick, that there's other projects in place, as Shannon mentioned, whether it's asthmatics or what have you. So we're looking at all of those. I think it can be done. I think that the fact that there's all these, as Yak said, there's great answers, I'm certain, that here in this room, and hopefully the next few days we'll be able to find those, and we can help scale them as well.
Shannon, are you getting the notion to prescribe an app at your innovation center?
Absolutely, and I think it's something we'll be doing in the next 6 months, and it'll be a coordinated program that might be the app, text message, something with the patient portal, combined with something you might fill in on the iPad in the office visit. I have the unique ability, because of the way we're set up, to have time to work on this stuff. So, a lot of health systems don't have the opportunity to really allocate staff from an innovation perspective, and I think that's where the challenge is. From my perspective, I can take multiple vendor input, I can figure out how to do it in the provider office and how to get it integrated in the medical record. But if you're out there and you're trying to do stuff with your normal staff and fit in the projects, you're going to be extremely challenged until you get, a vendor or a group of vendors really working together to do that for you. So I think my position is not something that is going to happen for everybody, because not everybody has that opportunity.
So I thought I would maybe close by telling a little personal story. So I have a son with a congenital heart defect, and he carries a device which was just approved by the FDA last week from AliveCor, which turns his smartphone into an ECG device, and he carries that with him anywhere. And so last summer we got a phone call at 1 in the morning where his uncle and aunt were driving him to the hospital for a tachycardia event, which was uncorrectable by his own actions. And when I called him while he was in the car driving down the mountain in remote Montana to the hospital, I asked him how he was doing. He said, fine. I said, what's your heart rate? He said, 214. I said, how you feeling? He says, fine, Dad, everything's going to be okay. And he said, I've already taken care of it. What do you mean? Now, this is something we had not taught him to do. He says, well, I used my AliveCor device. I recorded my ECG and heart rate. I asked my aunt to get hold of the ER and get an email address from one of the ER nurses. And I've emailed her my diagnosis, my rhythm, my heart rate, and a request to have my adenosine IV ready when I arrive in 35 minutes.
Wow.
Now, we didn't train him to do that. He figured that all out on his own. And I can tell you, I had the chief of cardiology at USC, who's a good friend of mine, call the ER doc in Montana and said, what was it like to have a patient self-diagnose, give you the clinical evidence, and give you his expectation of when and how he was going to get his treatment and specify the treatment? And he said it's never happened before. So I think that's just a little window in perhaps into the future of mHealth, a little example of a simple tricorder actually in play, one you can actually now go get that's FDA approved yourself. So I'd like you all to thank my panel. I think it's been great. Appreciate you all being here. Thank you.
Great story.
Thanks, Lee.